People again, my grandma Ruth, my grandpa Hassebrock. And so my thesis, while ethically and historically involved, a lot of ethical documents talking about care providers, talking about military roles, and also while talking about the history of the system, because I had to know what it was, also contains a very unique component. My grandfather was injured 2 weeks after he stormed Utah Beach in Normandy on D-Day operations. And as he made his circuit in care facilities here, there, all over the place, London, England, France, and then all the way back to the United States, him and my grandmother wrote love letters back and forth. And that's really what they were, is love letters. So I had to sift through a lot of stuff. But the more that I read them, and Dad read these with me, so he actually really enjoyed this part of the thesis. The more I read them, the more I found out my grandfather had absolutely no idea what was going on with him. He was sitting there writing letters saying, I want to go home, I can't wait till we get married. Dr. Clayton was crying. But at the same time, he's also saying, I think the doctor's going to show up today, tomorrow, maybe next week. He said I needed surgery, but he also, another doctor came through and said I didn't, and they don't know if they're going to move me back from the field station to the backwards line. Dad, you got to stop. And so what happened is he has absolutely no idea what's going on with him. And it pissed me off, because it's contrary to everything I've been taught about being a physician, everything I've been practicing here at Regis, everything that I'm going into. And so it's a personal component that's involved with it that I tie in all throughout the whole thing. And so the next thing that we should talk about is, if I'm going to rail against this system, if I'm going to try and bring down the man, we should probably know what the system is a little bit. So here's a little quick overview of what I covered. The United States military started, I bet none of you can guess it, I have it up here. I'll give you the first three digits. Can anyone guess the fourth? 1770, anyone?
5.
4? Close. 4 and 6, let's go in between. 5. So we actually have inception of the system before we have a United States, which is amazing if you think about it. And the really funny thing about that, and Tim will give me a hard time for this, is that we're actually starting with an apothecary general. No doctors or surgeons or anything like that. We're more like barbers. And so then there's a lot of great, amazing things that happen as we develop, right? Medicine develops, all sorts of things develop. But I'm going to focus on World War I because it's so absolutely phenomenal when it happens. It's just earth-shattering, the ramifications of the system that emerges. And so what emerges first and foremost is a foundational triage system. So you have categories. When a medic or a physician gets somebody dead on arrival, moderately injured, mildly injured, right? 3 categories. In World War II, this expands with everything else to dead on arrival, moderately injured, high amount of resources need to be allocated to fix this person, or moderately injured, low resources, or mildly injured, right? So we have an expansion and a clarification of this triage practice that happens. It happens in hospitals here, but typically nobody in the hospitals here has to take bullets being shot at them while they're making these decisions. And also we have this thing called echelon formation, which is kind of what I was talking about with my grandfather. At this time, there are 2 different systems basically in practice. There's the British system, which focuses on utility and transport. So utility means stop the person from dying immediately. If their wound's really bad, send them back to somebody more capable behind. If it's mildly bad, send them back to somebody more capable behind. Treat them as they move, stabilize all along the way. We also have the French system, which is why I have Napoleon up here, which is focused on liberty. It's allocating resources based upon need immediately. So Napoleon's Surgeon General actually pioneered a system earlier, obviously, called a moving aid station, where he had all his resources in one central location, and they moved all around the battlefield to the areas of highest conflict, and they did everything they possibly could right there. There was no other transport. And so I looked at how these developed, and in World War I is where we really see the United States choose one over the other. This is the system that we're going to live with as we've made this choice. It's my grandfather's records that followed him everywhere that he went. And so now that we understand how the system's set up, that we function in, obviously we've gotten a lot better. You can just look at the helicopter versus the first car. We need to examine the physicians we placed in this system and what their ethical alignment is. So this starts way, way back with a fellow named Hippocrates, which we get the actual ethic and oath from the physician interaction. Now, when most medical schools don't follow this exactly the same way it used to be followed, he's the first person to really put down and say, physicians healing somebody, care providers healing somebody is a unique human interaction that has a unique implication between the patient and the healer. So I'm calling this the physician as a healer role. This is what it's called in the literature. And he's an odd fellow. He actually thought surgeons were more like voodoo witch doctors. So this is just doctors here, and that's why we've had to change it up as it goes. So to analyze that, I have surgeons asking themselves if anybody here didn't take the Hippocratic Oath. So clarification issues emerge as we go. Now we have physicians who act more like businessmen. We have physicians who act more in the MPH role, which really looks at utility in the public health sphere. And we still have physicians as healers. And I'm going to argue that this is the fundamental paradigm. We're teaching our medical students right now this big push towards primary care. Jesuit schools really put this forward. Cura personalis, I don't have to tell that to this crowd. So physicians as someone in a relationship with an individual who they're responsible to. And that relationship is defined in three folds. Illness. The sick person realizes that they're in an unnatural state of being. Their body is contrary to what it should be in some way, shape, or form. They realize that they cannot by themselves fix this form. Then there's profession. Somebody who professes the knowledge and ability to fix this, and is thereby, a contract is sealed between the two. A cry for help and an implicit trust and faith, and then an implicit acceptance of this help, and now the responsibility to respond, and I would argue with the best of your ability, if you're claiming to be this. And that's when the third tenet happens, the healing that we're talking about. And so as Hippocrates himself sort of started to define this, boom, that's immediately when the problem emerges. This is a picture of Hippocrates and the Persian king Artaxerxes, always struggle with that one, and his messengers that he sent here, Artaxerxes. And at this time, Greece and Persia, not so friendly, kind of like North and South Korea. So the messengers are saying, Hippocrates, please help us. We're dying of plague. We need your skills. There's an endemic or epidemic in our society. And Hippocrates is being told by all of his fellow Grecians, don't you dare help these people. You have no business helping these people. You have an allegiance to the state, to the nation, nationalism, boom, there it is, first and foremost. And this is what he does. You see here, he's rejecting them. That's his first step. So I'm calling this a first instance of mixed agency. I'm sure it's happened in some way, shape, or form, but not in the literature I got to cover. But this is not an isolated incident. It's not an antiquated problem. It's more modern in all of its things. So let's look at a slightly more modern example. This might look familiar. It's some Vietnam caricatures. In Vietnam, the United States military created something called the Aid Men, which violated Geneva Conventions that medics, somebody who's got this delineation, should not be armed, they should not be a combatant, they only carry a .45 self-defense pistol. The Aid Men was created under the guise of winning the hearts and minds of the people of Vietnam, which was our primary strategy or overarching theme there. So the Aid Man is somebody who wields an M16, he is somebody who kills people, he is somebody who carries out combat roles, and yet he's taught rudimentary health care. He knows how to implant IVs, he knows how to bandage wounds, heal burns, and he's specifically told to delineate this care to people who are going to be pro-United States in their areas as they go through, and only to those people, right? Which is not what combat medics do, by the way, just for clarification. And so we get this problem, and a physician named Howard Levy says, wait, I can't do this. He's drafted, and we also have to remember this is 1967. Vietnam's not particularly popular. He says, I'm not going to do this. This is contrary to what I believe. It's contrary to what I'm taught about medicine. And the United States says, well, I'm sorry, you're drafted, you're a soldier, it doesn't matter what you believe or are taught about medicine. And they court-martial him and convict him, and he's sentenced to 3 years. But lest you think this is just an antiquated Vietnam situation, I've got a more modern dilemma for you. I worked with this in the junior seminar because it was a striking incident when it came out. This is Specialist Chazzaray Clark. Specialist Chazzaray Clark is an Afghanistan vet, or was, who was driving a Humvee on a mission, coming back out of an area where they carry out operations, when unfortunately him and his crew ran into an IED, an improvised explosive device. Specialist Clark was immediately severely injured. There's footage which is quite terrifying because an independent reporter was there doing operations on the war. If you look at Dexter Filkins' Forever War, it's a similar sort of thing where reporters there just reporting what's going on. And so he's terribly wounded. They stabilize him as best they can, but he needs urgent care. This is a Class A injury. This is a in-between dead on arrival and high resource moderate injury on the triage scale. His crew puts in a call for one of these, a medvac. This is how we get our boys now. And yet they're grounded. They can't leave. And the reporter is just incensed about this, and he says, why are they grounded? Because even though Specialist Clark's area that he's coming through, they've done operations, they've cleared, there's no one there, he is in what's called a hot zone. He'd been carrying out a combat mission, and so even though he was coming back from this, it's called a combat area, a hot zone, and you cannot go into those with an unarmed personnel carrier without one of these, which follow them and protect them. And there are good reasons for this. There are utilitarian reasons for this. But unfortunately what happens in this instance, nobody else is hurt. They finally get him after being delayed 45 minutes on tarmac. He makes it back to a hospital in 59 minutes, which is under the required reporting time for these injuries, so the Army does not have to self-report that they violated their code. But he's 45 minutes delayed. He dies in transit on the plane, a couple minutes before, on the helicopter, a couple minutes before he makes it there. And so I cannot justify this system. As effective as it is, as low of these sorts of results as it produces, it still allows for them the inflexibility of one ethical structure, the military system, over that of these people who really wanted to go get this young man. So what do we do with this system? If you have any answers, please enlighten me, because I'm still working on it. Dr. Franco talked to me and she said, Jeff, you've got to pick something. You've got to say something besides this condemnation. And so I said, okay, in a perfect system, the military physician would have more autonomy. I know what you're all thinking. That libertarian standing up there, that autonomy means something like this, right? I promise you it doesn't mean that. Autonomy means more the physician being able to ration out care as he sees fit in an instance like this. Those medvac people being able to say, we want to go get this person, we're going to take the risk, we can. Now